Alrighty, week 2, inflammation and stress response. So an inflammatory response is going to have the purpose of neutralizing any potential invading harmful agents. Like let's say you got a cut on your arm. Part of the first thing here is that the inflammatory response is trying to neutralize anything that may have been on that blade or may have been on the surface of your skin that then got into that cut, trying to neutralize that. And they limit the spread of harmful agents to other tissues by trying to increase the amount of fluid, increasing the number of white blood cells in that area, producing an environment that is not hospitable towards bacterial or fungal growth, and then also to help prepare for repair of the damaged tissues. I don't really understand. I mean, I kind of says the same thing here. So we have the cardinal signs and symptoms of inflammation, and anytime you see the suffix itis means inflammation of whatever the root word was. So we have redness, which is rubor, swelling, which is tumor, heat or warmth, which is calor, and pain, which is dolor, and then there's also loss of function. Pretty typical signs and symptoms of inflammation. So just because you have inflammation does not mean that we have infection. Typically, hopefully always, whenever we have infection, we will also have inflammation, but there are plenty of times where we may have inflammation but not infection, such as strains and sprains, myocardial infarction, properly performed surgery, blisters, thrombophlebitis. When it comes to inflammation, there are two types. There is acute and there is chronic. Acute is going to primarily involve neutrophils, whereas chronic is going to primarily involve monocytes, lymphocytes, and macrophages. As you can imagine, acute is short in duration, typically less than 2 weeks, and it involves a discrete set of events, including vascular permeability, cellular chemotaxis, and systemic responses. So that vascular permeability, the purpose here is we want to kind of dilute the toxins, the microbes, whatever may be in that area that came from the original insult, to limit how destructive they can be on the surrounding tissues. That extra vascular permeability allows also for white blood cells to invade the area and help protect the cells, and allows also for platelets to invade that site and allow for the coagulation to occur. The increase in fluid also helps to decrease the pH of that area, which will inhibit microbial growth. Cellular chemotaxis is really just saying, hey folks, we want you platelets and white blood cells to get over here, and because we got a situation. These are going to be just chemical signals that come from microbes or endothelial cells that are broken, and from white blood cells that happen to be in that area when the original insult came. Systemic responses also exist, and most of the time they seem to occur from or when the inflammation becomes a more systemic process rather than just a localized thing. And they're going to be including the typical signs and symptoms like fever, pain, lymphadenopathy, which is just swollen, tender lymph nodes, anorexia, sleepiness, lethargy, anemia, weight loss. And then inflammation can also become a chronic situation that extends over more than 2 weeks generally, and it's more often a more diffuse issue rather than a localized pinpoint area that you can identify easily, and there's a greater chance of developing scar tissue from the severity of that injury. So when we have the inflammatory response, kind of similar to what's said over here, we get increased vascular permeability. We want to get all those fluids in there, get the white blood cells get in there, the platelets and all that stuff, which recruitment, emigration of leukocytes, white blood cells. And a lot of those white blood cells, or some of those white blood cells and other immune cells will phagocytize antigens and debris and help get the area ready for healing. So we have 4 of our 5 cardinal signs of inflammation. Vasodilation does a bulk of these, creating pain, heat, and redness. Swelling occurs from that increased permeability, all that fluid coming out, along with the neutrophil emigration, not immigration. We have also some systemic manifestations of inflammation, like I had mentioned earlier, the lymphadenopathy, fever, pain, anorexia, sleepiness, lethargy, anemia. These are all really these are attributed to responses from interleukin-1, interleukin-6, tumor necrosis factor alpha. These are all cytokines. They're released from macrophages or inflamed tissues, and they help to signal other guys to say, hey, come on over here and help us fight these things. And they also help to sort of adjust things like the set point for the temperature, body's temperature in the hypothalamus. When we measure the body, do certain lab tests, measure the body, to determine whether or not someone has some form of inflammatory system or issue going on, we can check C-reactive proteins, also known as CRP, and erythrocyte sedimentation rate, or ESR. Both of these are good for determining systemic inflammation. Neither one is very good towards identifying the root cause of the inflammation, where it is, what caused it, whatever. Just that, hey, there's a problem going on. With ESR, what's going on here with erythrocyte sedimentation rate, kind of just an interesting tidbit. Fibrinogen will increase with any kind of injury, especially a major one that involves or promotes a systemic response. And that fibrinogen is going to then coat red blood cells, and it makes them heavier. So when they are put into a solution, they will end up dropping faster compared to red blood cells of someone who is not having an inflamed reaction or inflammation response. And so that's how they tell. Just kind of thought that was nifty. So exudate is a fancy term for just some sort of like a fluid that is released by the body. And the purpose here, I think exudate can also include blood. I can't remember exactly. But all that extra fluid that gets leaked out through the capillaries to any inflamed or injured tissues, their purposes here are going to be transporting white blood cells, leukocytes, and antibodies to the area that's injured, diluting those toxins to help make or irritating substances, to limit how much damage those substances or toxins can cause to the non-injured tissues, and transport nutrients for tissue repair to that area to help get repair going. We have several different types of exudates in the body. Serous is going to be that of like in a blister. So it's very watery, it's very low in protein, virtually clear, comparable to water if you were to look at it side by side. Serous sanguinis, let's say we had that blister, it kind of became a bit more inflamed. It was a more pronounced blister, and so the edges around it became more inflamed, the capillaries and the edges became more leaky, and we got a little bit of kind of blood fibrinogen from those leaky capillaries into the blister, into the serous fluid in the blister, and now we've got serosanguinous. Not really that big of a deal. You just know that there's a bit more inflammation than simply the blister. Fibrinous is going to be a very thick and sticky, high protein fluid. This is going to be an implication that there's a much higher severity of injury going on, because the capillaries have become so permeable with the intention of getting as much fluid, as much white blood cells, as much helpful cells and nutrients to that site of injury, that we're also they're leaking out fibrinogen and proteins as well. And so that's why it becomes a bit thicker, stickier, all that. Purulent, this is just a pus which is filled with infective organisms, the white blood cells, leukocytes that are attacking them, and the cellular debris of the now destroyed, ineffective, or infective organisms that have become prey to the white blood cells. Hemorrhagic, that's blood. Chronic inflammation, so we got a little extra stuff here. So in acute inflammation, the products of activated macrophages will eliminate injurious agents and initiate the process of healing. So that's good. In chronic inflammation, the constant secretion of these products, such as free radicals, proteases, cytokines, angiogenesis growth factors, which is just a fancy way of saying growth signals, chemicals that are given to help promote the development of blood vessels, and fibroblast activators. The constant release of those products causes long-term tissue damage because they're constantly being produced. The tissue is repeatedly damaged, healing is delayed, and connective tissue replaces injured cells because they're like, oh my gosh, we aren't able to get these back to what the original cells were. We got to find some sort of solution because this ain't working. That's all to be said that macrophages are essential for wound healing, but if they stick around too long, it becomes a major problem. With that chronic inflammation, all of those products being produced, there's a potential that we can then develop a granuloma, especially with certain types of disease processes. A granuloma presents as a distinct histological pattern, and it comes from macrophages aggregating and transforming into epithelial-like or epithelioid cells, which are surrounded by lymphocytes, fibroblasts, and connective tissue. And they oftentimes will then fuse together to form giant cells within the granuloma. The most common type of disease process that displays this is going to be tuberculosis, TB. And here what we're going to have is a bunch of neutrophils, a bunch of monocytes that surround the TB bacteria. They're trying to destroy it, but they can't because TB has become so powerful and resistant to neutrophils and monocytes. So what they do is they wall it off with a whole bunch of lymphocytes and fibroblasts and connective tissue. And they have kind of permanently encapsulated this grouping of TB cells. They can't get out, they can't really go anywhere or do anything, but they're kind of sitting there and it's this constant site of inflammation. And that's called a tubercle, which is where we get the term tuberculosis. Okay, so we can have localized manifestations of inflammation like our 5 cardinal signs occurs with both acute and chronic inflammation. And then systemic, we have all those things. For tissue healing, we have our 3 stages. We have inflammation, which is what we've been talking about this entire time. We then would move on to reconstructive or proliferative stages. This is where we're going to end up getting a bunch of granulation tissue forming within the injured site. So fibroblasts, these are our primo guys here. They're going to synthesize collagen to replace the damaged or missing extracellular matrix, and they form, which forms then the foundation of wound healing. Some of that, maybe all of it, may form into some sort of long-term or short-term scar tissue. That's okay for sometimes. This stage can start typically 3 to 4 days after the injury, can persist for 2 weeks, 3 weeks. It's conflicting information in the books. after which point they will enter the maturation or remodeling stage. Here we're going to have wound contracture, which is going to be the pulling of the two sides of a wound together. If we have a nice clean cut, that's a really simple, easy maneuver. If we're talking about a pressure ulcer, that could take months to potentially even years to really fully heal, because if there's any pink left, that means it's still not fully healed yet. And yeah, but that would be the maturation stage. And here that wound contracture occurs via myofibroblasts, and the fibroblasts are still working here to work with the myofibroblasts to help refine, reshape that scar tissue to best match the original tissue. So again, kind of going back to the reconstructive phase here, maybe I should have looked a little bit further ahead before speaking. So with the reconstructive phase, those fibroblasts are going to rush to the wound to replace the extracellular matrix and promote wound healing. And also the endothelial cells, along with those fibroblasts, are going to form that granulation tissue. And that granulation tissue will actually secrete cytokines and growth factors to help promote the healing. And then epithelial cells are going to end up migrating over there, signaled partially by cytokines, to form a new surface, fill in the gap between the wound edges. And then after that, it's going to enter the maturation stage and kind of get things refined into what they should be. So that's part of the reconstructive phase. So myofibroblasts are really more a part of the maturation phase rather than the reconstructive phase, at least according to the two books that were provided. Endothelial stage here, I believe, actually is still part of the reconstructive phase, but yeah, this part I believe should be over here. And it's the wound remodeling, it's that wound contracture, it's trying to refine, reshape all that stuff and make it as normal as it can be. So we have multiple reasons for why healing may be impaired if a person doesn't have enough nutrition, especially protein. Protein is the number one thing we need to really ensure proper healing. But really the entire full diet is required. Then that may impair healing. Of course, impaired blood flow and oxygen delivery to deliver nutrients and resources and remove waste products is important. If we have an impaired inflammatory or immune response, such as immunosuppression, if someone's with, for example, RA, rheumatoid arthritis, taking a immune system modulator, something that helps to kind of dull the immune response, that may impair some level of healing. Or someone who has HIV or cancer, diabetes, if they take a lot of steroids, if they are older, maybe if they're younger. And all of those can lead to a decreased white blood cell count or white blood cell response, making it more difficult to really have a strong immune response. Infection is the single most important cause of delayed healing because the body's primary purpose at that point is to get rid of the pathogen, not repair the damaged tissue. It impairs the formulation of granulation tissue and collagen synthesis. So I mean, we're talking about like we're constantly in this inflammatory state rather than beginning any stage of real healing. Wound separation, proper term for that would be wound dehiscence. Literally, the wound is spread apart. So you have a good, nice surgery. They did all their stuff right. Let's say it was in your abdomen. And you go home, do a little stretching, all of a sudden pop goes the weasel and your wound has separated. That would be a wound dehiscence and is a major no-no towards tissue healing. Foreign bodies are a significant issue. because the body can't really work around it as much. They want to get rid of that foreign body, and so that's going to promote a continuous inflammatory response. The younger you are, the faster and better your body tends to heal. But the older you are, the longer and more difficult it takes to heal properly. And then certain medications, of course, if you take them, can impair healing. Innate versus adaptive immunity. So the body is split up into the innate immunity, which is going to be basically your indiscriminate, that's not me, that's not part of this body, kill it response, as well as the let's prevent anything from getting in the first place part. So we've got like your skin, your mucous membranes, you got mucus inside of your airways, hairs in your nose, acidic environments. All of these things help to prevent pathogens from getting in the first place. If they do get in, we have things like natural killer cells, macrophages in specific parts of the body, the complement system. All of these things are going to do a great job of identifying, hey, you don't belong here, let's kill you. But sometimes it's not enough, at which point we then have to go on to adaptive immunity, where we then have things like cell-mediated immunity and antibody-mediated immunity. So cell-mediated, this is going to be involving your T cells, your CD4 helper T cells, your CD8 cytotoxic T cells, your antigen-presenting cells or APCs. These are going to be the ones where they identify something and they bring it over to the T cell and say, hey, T cell, we found this guy here. He doesn't look like he belongs. I think you should get rid of him. And then the T cell goes and destroys him. And then antibody-mediated immunity involves your B cells, your B lymphocytes, which are the immature guys, and then they mature into plasma cells, which are able to produce antibodies, and they respond based on what the T cells find, and they produce long-term immunity against anything that we're exposed to that isn't good. Okay, and we can also have passive and active immunity. So passive immunity is going to be where we get antibodies from our mother's breast milk when we are breastfeeding as an infant. Or perhaps we get immunoglobulins via an injection because of some sort of allergic response or immune system issue at some given point with some sort of disease process. Active immunity is going to be where we are exposed to an active infection. Someone with the flu sneezes on you, and now you have the flu, you were exposed to it, and your body developed antibodies and a whole host of defenses against that flu strain. Or maybe you got the flu vaccine, which helps to promote a sort of an artificial response to that flu strain in that shot. That would be active immunity. Okay, so now moving on to stress response. So again, touching on homeostasis and allostasis. Homeostasis, the way I like to think about it is homeostasis is the maintaining of physiologic set points. Allostasis, on the other hand, is the changing of those physiologic set points to match the stressors found in a long-term environment. So again, let's say we have a person who's living comfortably at home, no big deal, life is going hunky-dory, and then suddenly they're thrust into a war zone of some kind, long-term, and their normal blood pressure of 120/80 doesn't suffice towards ensuring the survival of the organism, the person, and so instead the blood pressure, the set point, gets changed from 120/80 to 130 or 140/90. Long term, that's bad, but in the short term, it's better for that person's survival. But the body doesn't think about long term If I go and have blood pressure of 140/90 for 20 years, I'm probably going to develop atherosclerosis. The body doesn't think that way. The body's thinking, holy crap, I might die right now, and this stressor does not seem to be going away, so I gotta change the set points to match what appears to be a long-term stressor. Um, okay, so eustress is also another term, is a positive form of stress. So technically, excitement is a form of eustress, as well as the sort of the stress, the anxiety that is naturally experienced prior to a test. Distress is going to be a negative form of stress. So let's say the stress before an exam is so strong that a person can't sleep. It's so strong that they end up having panic attacks, or they end up having so much stress that they are experiencing it still even after the exam has finished and after they've even had their exam results. That would be a form of distress. So there are a couple people who came up with some stress theories. Selye, I don't remember his first name. Selye has one theory, and he identified, I think it was a he, identified a stressor as a challenging demand on the body, arouses a response from multiple organ systems, again, can be positive or negative, and once that stressor is experienced, what kind of comes next is partially dependent upon a person's adaptive ability. So if that person has a good set of coping mechanisms, of ways they can go about managing that stress and having a strong supportive background for them to rely on, then they will manage the stress well and they will reduce the effect on their life and their body will then eventually return to homeostasis. Great. If it doesn't, then that homeostasis doesn't get returned to, and allostasis changes it to a different set point. So Selye goes on to talk about how there's a general adaptation syndrome. So when the stress is a threat to homeostasis, it provokes a coordinated adaptive reaction called the GAS, and that consists of 3 stages: the alarm stage, the resistance stage, and the exhaustion stage. So during that alarm stage, this is going to be a state of arousal of the sympathetic nervous system and of the adrenal glands. So we're going to have certain chemicals released such as epinephrine, norepinephrine. We're going to have certain hormones released like aldosterone, ADH, cortisol. And these are all going to work together towards helping this person overcome this stress of some kind. Like, let's say you're getting chased by a bear. I don't think that's overly important. That's pretty straightforward. So here's that person getting chased by a bear. So when we have that fight or flight reaction, we're going to have vascular smooth muscle responses as constriction of the kidneys, the skin, the GI tract, because those really aren't very important towards immediate survival. We're going to constrict the peripheral vasculature because, again, the fingers having solid, fine motor control is not super important. It's the gross motor control that's really important, which is why we're going to have dilation of skeletal muscle vessels, dilation of the bronchioles and the bronchi in the lungs, and big ol' umphness to the heart. We're going to call that a medical term, umphness. Catecholamines are going to be our norepinephrine and epinephrine. These are released by the adrenal cortex, I think is the cortex. Maybe it's the medulla. I always have a hard time remembering which one it was. Okay, so the cortex secretes glucocorticoids and aldosterone, and the medulla secretes epinephrine and norepinephrine. Okay, so those get sent out and do all those fancy things that were just mentioned, and then the adrenocorticoids are released by the cortex. Right? Did I get that right? The cortex? corticoids, cortex. We're going to remember it like that. And they're going to have a synergistic and sometimes antagonistic response alongside catecholamines. They have also a short-term and anti-inflammatory effect because that inflammation effect is not important towards immediate survival. It will be helpful towards wound healing in the longer run or medium length run. But you're wasting efforts, wasting energy on inflammation when instead you should be running and fighting. So next we have then the resistance stage. I felt like these kind of made it more confusing for me, so I found it in the book. The body continues to stave off the effects of stress through continual hormone and catecholamine secretion. However, this is a time-limited stage, so if the stress subsides, then the sympathetic nervous system and the adrenal stimulation will stop, and the parasympathetic activation or parasympathetic nervous system will activate to resume a state of relaxation. If that doesn't work, if the stressor does not subside, the high levels of hormone and catecholamine secretion cannot be sustained, and the exhaustion stage will then ensue. The body's resources are depleted, and signs of systemic dysfunction will occur. The signs and symptoms will include things like feeling run down, unable to cope, feeling depressed, anxious, physically ill, and then long-term secretion of cortisol will suppress immunity, and they will actually slow the white blood cell response. The thymus, which is part of the immune system, will also or can also atrophy, leading to a decline in T lymphocyte production, leading to further immunocompromise. So long term, if we don't find a way to manage that stress, whether that's an immediate, actual life-threatening stress, or it's a more internal, perhaps psychologically driven or emotionally driven stress, but it's profound, then we will enter eventually the exhaustion stage. That cortisol will continue to be released, but it will end up impacting our immune system's potential and will be compromised and more likely to become sick. So next up, we've got McEwen's stress theory. And this is a long-term stress theory rather than Cellier's more shorter reaching into long-term stress theory. McEwen really impacts allostasis, which is that dynamic state of balance that changes according to the exposure of stressors. And then allostatic load is going to be the long-term impact of all of the stress reactions that occur long-term that especially are not dealt with well, and the impact that makes to the different organs and systems in our body. An allostatic load may accumulate if we have repeated stressful experiences. So let's say you've got, I don't want to touch on anything too sensitive. So perhaps you've got multiple members in your family that died within a short time frame. That's a massive emotional, psychological toll on a person. And those repeated stressful experiences will add up substantially with an allostatic load. Or perhaps they weren't as severe as that. They were a little less severe, but the person does not have a strong sense of coping ability. And so all those more mild, minor stressors, because they weren't dealt with appropriately or healthily, add up in their own way towards a stronger allostatic load. Or perhaps there is a strange reason for why, or a unhealthy reason for why there is a prolonged reaction to a stressor. So maybe the person was being anxious about an exam well prior to when the exam came, and then for a long time afterwards because of fears of impact to their degree, or maybe there was no actual reason whatsoever. They just felt anxious about it and they didn't know why. Allostatic load can also accumulate because of an inadequate neuroendocrine response. So if we don't have enough cortisol in a response to a stressor, then that can lead to an inadequate shutdown of localized inflammatory mediators, leading to autoimmune and inflammatory diseases. I want to make sure I got that right. Okay. Okay, so you've got like a inflammatory response because of stress. Cortisol, part of its function is to help keep that under control in the short term. And if it doesn't exist, then we may have a super duper immune response because of that lack of cortisol. I believe that was said somewhere in the book in case anyone's confused, because I'm kind of confused. So our adaptive ability or allostatic load really is then dependent upon the severity and quantity of the stressors that we experience, but then also how we are able to manage those stressors as they come up, which also really is dependent upon the number and quality of resources that each individual may or may not have at any given time. And through using coping mechanisms. So we can then have allostatic overload when the stress exceeds the body's ability to adapt, and will initiate pathophysiologic disorders. So, but if that allostatic load is reduced, depending on how severe it's been, how severe that allostatic overload has been, and how prolonged it's been on that person, then they may be able to reestablish a healthy level of homeostasis. So if we have a positive, healthy lifestyle habits, a strong adaptive capacity, we will have allostasis, a healthy level of allostasis, leading to the ability to adapt to stress. If we have unhealthy lifestyle habits, we're sedentary, we don't exercise, we eat a really bad diet all the time, we don't get enough veggies, and if we have poor adaptive capacity, we kind of shut things down, we suppress them as opposed to dealing with them and seeking help. We will be at higher risk of allostasis overload. We will have maladaptation to stress and actually then potentially create a pathophysiologic condition. So take care of that stress. Some of the symptoms of allostatic overload include things like nervousness, irritability, headaches, lack of concentration ability, insomnia, changes in appetite, depression, panic attacks. And there are a whole host of adaptation methods. These are a few of them. Some of the things that we can do when at a point of extremely high stress is that we can reduce our caffeine intake, increase our exercise, not to the point of being super intense, but just enough to get our body moving a bit, because we don't want to add to that cortisol release or add to the stress that our body's already experiencing. Make sure we get plenty of sleep, plenty of good nutrition. Look into maybe a stress management program, maybe some pharmacology. Zoloft does wonders, and I think that is it.